Thank you. Capital R.
अभी लेक्चर ले रहे हैं ऑनलाइन है ना, अभी तो अवेलेबल नहीं होता।
जियो का नेटवर्क आपका कम आ रहा है। There's a network issue, but my voice is audible. Or...
The screen and you will speak out.
Sir, we are not on live till now.
चलेगा तो नहीं चल रहा ना पक्का।
So, sorry for the inconvenience. We are live now. You can start with your session, sir. Thank you.
Okay.
Thank you. Hello and good evening. Welcome to the expert cross-talk on Empagliflozin, multi-mechanism, multi-indications, and multi-benefits. As you already knew that ESC 2020 was memorable with the path-breaking clinical data presented from multiple global trials. This program is designed with the objective of dialogue between two different specialties, cardiology and endocrinology, which are bring upon two different ways to address the complexities of the clinical cases in heart failure. So according to Emperor trial, does SGLT2 inhibitor may be considered as an important drug for HFrEF? But let me introduce today's speakers. Nirdesh, Jain, and Dr. Anshul Agarwal, and I am moderator Dr. Shavik. Dr. Anshul is a considered endocrinologist at Vinayak Hospital at Jhansi, and his area of interest are diabetes, thyroid, parathyroid, hypertension, PCOD, and many more. I welcome Dr. Anshul in this expert webinar. Our next speaker is Dr. Nirdesh Jain, who is a consultant cardiologist and assistant professor in cardiology at MLB Medical College, Jhansi. Dr. Nirdesh has several national and international publications in his credit and also presented various papers in national and international conferences. Welcome Dr. Nirdesh in this expert webinar. And I'm handing over the session to Dr. Anshul to start with the presentation. Thank you.
Thank you, Shovik.
Yeah, it's visible, sir. You can start. Yeah.
So thank you for the nice introduction. So we'll just start with the topic. Today's topic is on empagliflozin, which has multi-mechanism, multi-indication other than diabetes, what we think so, and has multi-benefits also. Coming to the endocrine perspective of empagliflozin. Okay. So SGLT2 inhibitor actually what we do, they modulate range of factors which are related to cardiovascular risk. So they can, other than reducing the sugar, what we see in the reducing the sugar, they also reduces the blood pressure, which is a major cardiovascular risk factor. Other than that, it also helps in reducing the weight, decreasing the oxidative stress, improving the cholesterol profile, lipid profile, by improving the HDL and decreasing the triglyceride, decreases the hyperuricemia, decreases the albuminuria, and has some role in decreasing the sympathetic nervous system activity also, which is altered in diabetic patient and has key role in causing the cardiovascular risk. And this sympathetic nervous activity control has been thought and hypothesized because of increase in the ketone formation by the SGLT2. So other actions of SGLT2 which might aid in help, sorry. So other actions of SGLT2 which might help in improving the cardiovascular risk profile along with other drugs which are used in cardiovascular uh, patients like AC inhibitor and neprilysin inhibitor. They also cause increased natriuresis, improves the cardiorenal physiology, and decrease preload. So if SGLT2 is prescribed along with all these drugs, it might also help and aid in improving that cardiorenal physiology and decreasing the preload, afterload, and also decreasing the stress and also decreasing the interstitial edema as along with diuretics. So coming to the brief physiology of SGLT2 inhibition, we might all be knowing about the SGLT2, how it acts, but just a brief summary. The SGLT2 channels are present in proximal convoluted tubule in the S1 segment, and SGLT1 is one of the first three segments of proximal convoluted tubule. SGLT2 is responsible for 90% absorption of the glucose from the PCT. So as the name suggests, SGLT2, sodium glucose link co-transporter. So it is responsible for the absorption for the sodium as well as glucose. So if if after inhibition, the sodium and glucose absorption will not occur and will lead to natriuresis and glycosuria. And this glucose excretion will also cause osmotic diuresis and will also cause increase in the free water clearance from the body of diabetic patients. So what all drugs are available in the market is mainly the three drugs are available in SGLT2 like empagliflozin, DAPA, and Cana. These all drugs are mainly marketed right now and are being commonly prescribed because they have been shown to have cardiovascular benefit and safety has been shown with EMPA as well as Cana, and DAPA has shown benefit in heart failure patient. Other drugs which are available are like remogliflozin, till now is not shown to have cardiovascular benefit profile, and another drug like sotagliflozin is in pipeline, which has combined SGLT2 and SGLT1 activity. So coming to the pharmacological profile of these three drugs, we might all be knowing that empagliflozin initial starting dose is 10 mg and maximum dose is 25. DAPA, we start with 5 to 10 and CANA 100 to 300. The pharmacological profile of all these three drugs are almost the same, and elimination and absorption is almost the same. Thing to be noticed is in the selectivity over the SGLT2. As we see in empagliflozin, it is around 5,000 times more selective as compared to SGLT1 in empagliflozin, and other drugs are not that selective, like DAPA is 1,400 times selective and canagliflozin is 160 times selective to SGLT2. So coming to the efficacy and how the empagliflozin can reduce the cardiovascular risk, the major risk which can cause cardiovascular disease is the glucose per se. So SGLT2 inhibitors itself can reduce the HbA1c. So we can see in this data, monotherapy can reduce the HbA1c by around, this blue graph is showing around 10 mg dose and red is showing 25 mg of empagliflozin. So monotherapy can reduce HbA1c by 0.74 and higher dose can reduce by 0.85. Empagliflozin along with metformin can further reduce the HbA1c by 0.57 and 0.64. And similarly, on another drugs, if we add on empagliflozin, it will further reduce the HbA1c by around 0.5. So it has modest benefit in reducing the HbA1c. Another major risk factor is body weight. So SGLT2 also takes care of in that. Empagliflozin in this trial has shown that monotherapy can reduce the body weight by around 2 kg. 10 mg can reduce by 1.9 as a monotherapy, and 25 mg can reduce by 2.2. And if we give as an add-on therapy along with metformin or pioglitazone or sulfonylureas, it has further weight reduction. So we see some reduction in the blood pressure, though not so significant. No, so this blood pressure effect is not in the one time of the. So there's a clear widening of the graph after week 12, and similarly, there's also a dip in the diastolic BP of around of 10 mg and 25 mg. So coming to the another CV risk factor like lipid profile, there's also some alteration in the lipid profile and some improvement also like LDL is slightly improved with SGLT2, 10 mg of empagliflozin and 25. Similarly, triglyceride is decreased. You can see that the LDL is increased by 3 and 3.9. But if we take LDL and HDL ratio, it is almost the same as compared to placebo. So there's some alteration and improvement in the lipid profile, which might also help in improving the cardiovascular risk by empagliflozin. This is also one of the meta-analysis of several RCTs. One of the meta-analysis has shown a very great benefit of reducing HbA1c by 1.56 and BMI by around 1.5 kgs. And another has shown a modest benefit of reducing HbA1c by 0.6 and body weight by 1.5 kg. And similarly, what I have explained before, as an add-on therapy also, it might reduce the HbA1c by 0.5 and might reduce the weight by 2 to 3 kgs. So whether once we prescribe these drugs, we have looked after the efficacy, pharmacological profile, and physiology. The major effect now which the physician must look after is the about the side effect profile, which before prescribing any medicine. So what safety profile in the empagliflozin, you can clearly see that major effect of side effects are seen in UTI, urinary tract infections, and genital infection. Other known effect and suspected effects like pyelonephritis, urosepsis, and volume depletion is not so shown too much significant as compared to placebo. Infection and UTI is much common in empagliflozin. So coming to this graph, here you can see that patient with blue one indicates 10 mg empagliflozin and gray one is placebo. As compared to placebo, there's almost equal adverse effect, almost the same as compared to placebo. And patient with serious effect is also the same as compared to placebo. So what we can see is that the adverse effects are not that common, which would lead to discontinuation of the drug of empagliflozin. It is a quite a safe drug to be given along with the efficacy which I have already shown. So for all these mechanistic actions has been shown to improve the CV risk, but whether this has come in the trial or not has to be shown before giving to any of the patient. So there was a landmark trial, EMPA-REG outcome trial, was published in 2015, and after that, it has changed the diabetic prescription among the physician and endocrinologist, because in this you can clearly see there's a reduction in the clot favors empagliflozin. Non-fatal stroke was other than that, CV risk reduction, the subgroup and overall composite renal outcome has been improved in 46%. There has been shown to have reduced heart failure hospitalization or cardiovascular death. And this shown to have significance has been reached day 17 itself. And within weeks to months, it provides the cardiovascular benefit, which has favoring empagliflozin in heart failure subgroup. Myocardial infarction and stroke, there is not much improvement with any of those drugs, though that curve is showing towards the favoring empagliflozin. And subgroup analysis has also showing improvement in the all-cause mortality in empagliflozin group as compared to DPP-4 inhibitor. So empagliflozin is clearly showing improved mortality benefit and hospitalization to heart failure as compared to the patient who are on as who are on empagliflozin versus DPP-4 inhibitor. So coming to the guidelines still speak the first line therapy as a metformin and lifestyle changes. But once these thing doesn't work, and then we have to look for the second line. Second line, if there is a indicator of any atherosclerotic cardiovascular disease, CKD or heart failure, you should always think of GLP-1 receptor agonist or SGLT2 inhibitor. So So first line should always be a metformin with right lifestyle changes, and second line we have to first think about the CV risk. If it's CV risk or the CKD risk, whatever predominates, we should start with the SGLT2 with proven cardiovascular benefit or GLP-1 with proven cardiovascular benefit. Thank you. So I will hand over this next session to Dr. Nirdesh for cardiologist perspective for empagliflozin.
Nicely presented, Dr. Anshul. Nicely and very briefly, we have covered everything.
Thank you. Thank you, sir.
So now I'm going to discuss about the cardiological benefit of empagliflozin and other SGLT2 inhibitors. This table shows the various trials conducted on various SGLT2 inhibitors like EMPA, CANA, DAPA, and empagliflozin.
Sorry to interrupt, sir. Dr. Anshul, can you stop sharing the screen so that
Sure.
you can share the screen?
Yeah.
Yeah, thank you.
So various molecules, as Dr. Anshul has told, have shown there is improvement in the heart failure rate of heart failure, reduction in the heart failure hospitalization rate. So in EMPA outcome, there is 35% reduction in the heart rate hospitalization for heart failure. In other trials for the canagliflozin, there is 33% reduction. In declaratimi, it is also shown 27% reduction in rate of heart failure hospitalization. And a trial for etogliflozin is also has shown 30% reduction in the heart failure hospitalization. But only the empagliflozin has shown reduction in the cardiovascular death, whereas other molecule could not show similar reduction in the kidney outcome. It was reduced by 35%. Framing was higher for total cardiovascular disease. For heart failure was higher. It is a more common outcome than MI. And stroke and death in diabetes patient trials, whether it is look ahead, life, renal, IDNT, proactive, altitude, and various large US registries. So heart failure is a major cardiovascular outcome that is measured in trials. It is larger than MI or stroke. So we all know that the effect of more versus less intensive glycemic control on MI and heart failure resulting in hospital admission or death. So the old landmark trials for the ACCORD, Advanced Equipedias of Wet Study for the myocardial infarction, only the ACCORD study has shown the significant, um, uh, this plot shows the clear demarcation to the favorable. Other trials could not show the benefit of reduction in the glucose control translate into decreased risk of MI. Whereas the heart failure hospitalization rate was also not translated into by these trials to reduction by these trials. So these trials could not show the benefit, overall benefit resulting in the hospital admission or death. For various clinical trials of glucose-lowering agent in patient with diabetes, if we see in the Wikipedia's sulfonylureas in origin insulin and proactive in record, uh, Alexa leader, GLP-1 agonist, Sever, Tecos, and Examine, they have taken DPP-4 inhibitor or Impareg. So by seeing this plot diagram, we can see the only EMPA has shown the reduction in the heart failure outcome, whereas other glucose lowering agent could not show in the cardiovascular safety trial. Evidence for benefit of SGLT2 inhibitors on heart failure risk in patient with diabetes. So Impareg, I'm briefly describing the 11,531 patients were screened and among them 7,020 patients were randomized and treated. So 2,333 patients were on placebo group, 2,345 patients were in empagliflozin 10 milligram dose group, and 2,342 patients were kept in 25 milligram empagliflozin dose group. The key inclusion criteria was adult with diabetes and established cardiovascular disease. Among them, 10 point between 7 to 10%, and EGFR is more than or equal to 30 ml screening, and elevated anti-proBNP level more than 300 picogram per ml, those who without AF, and more than 900 with patient with AF. So these were the inclusion criteria for the patient. And patient were screened for less than 28 or equal to 28 days. In Emperor reduced trial, 3,730 participants were enrolled, and out of them, empagliflozin 10 milligram were given in few patients, and in the another arm, randomization was done, and the follow-up was done for 20 months. And so it was the only design of the trial. The main chunk is the result of the trial that I will discuss here. So Emperor reduced trial by adjusting eligibility based on natriuretic peptide level to baseline ejection fraction. This trial will preferentially enroll high-risk patients. A large proportion is expected to have an ejection fraction less than 30%, and estimated annual event rate is expected to be at least 15%. I just would like to highlight, because before this trial, DAPA-HF trial has already shown the benefit in heart failure rate reduction. But the difference was that in that trial, the patients were taken were mild to moderate LV dysfunction. So in mild to moderate LV dysfunction, the results were clearly beneficial. So this trial was conducted to see whether these results were translated in patients with reduced ejection fraction or not. So here the patient was severe LV dysfunction. Those with the less than 30 ejection fraction were tried to take in, and those have estimated annual event rate is approximately 15% were taken. So what the mechanism that is responsible for benefit in patients with heart failure with reduced ejection fraction? So one hypothesis was proposed: these inhibitors increase fasting level of ketone bodies. So the failing heart, efficiently metabolize, it acts as an efficient metabolic fuel for failing heart. However, these finding in experimental studies consistently were not supported. Another hypothesis was that these inhibitors also inhibit sodium hydrogen exchanger 1 in myocardium, and that is responsible for overactivity that causes increase in the intracellular sodium and calcium, which can impair cardiomyocyte function and viability. So empagliflozin inhibit the activation of calcium calmodulin dependent kinase 2, which contribute to the activation of sodium hydrogen exchanger 1 in the heart. So the action of empagliflozin to prevent calcium overload may explain why the drug prevents time-dependent decline in systolic cardiac function seen in experimental pressure overload induced heart failure. So this mechanism is also responsible for reduction in heart failure with preserved ejection fraction. This trial has come into it is published in August. The outcome of Emperor Reduce is published in August 2020 in NEJM. So Emperor Reduce trial specified only 3 endpoints to be tested in hierarchical manner. Primary endpoint was considered composite of cardiovascular death or heart failure hospitalization. It's very important. Only two things. The first secondary endpoint is total first and recurrent heart failure hospitalizations. Second secondary endpoint is the slope of decline in glomerular filtration rate over time. The Emperor reduced trial showed that the empagliflozin is superior to placebo in improving heart failure outcome among patients with symptomatic stable heart failure with reduced ejection fraction, irrespective of the diabetes status. So other molecule also has shown the similar findings except for Cana. The goal of the trial was to assess the safety and efficacy of empagliflozin in patients with symptomatic heart failure with reduced ejection fraction, irrespective of the. I will briefly look into the design of the study. Study were randomized into 1:1 fashion to either empagliflozin 10 milligram or matching placebo. All the patients were receiving appropriate treatment for heart failure. So total patients screened were 7,220. Total duration of follow-up was 16 months. Mean patient age 67 years and females were around 1/4. Patient included age more than or equal to 18 years. Those who have chronic heart failure, new or NYHA function class 2 to 4, LVF equal or less than 40%, heart failure hospitalization within 12 months, and various range of anti-proBNP, and threshold was doubled when concomitant AF is present. Patients were excluded, very important, acute coronary patient, coronary syndrome patient, stroke, or TIA within 90 days, and those who have listed for heart transplantation or those currently on implanted LV assist device. Cardiomyopathy based on infiltrative accumulation disease, muscular dystrophies, hypertrophic cardiomyopathies, pericardial restriction, peripartum cardiomyopathy, or cardiomyopathy caused by chemotherapy within 12 months. So these were excluded. Patient with severe valvular heart disease. Another important thing, acute decompensated heart failure, or those patients who have put on ICD or CRT within 3 months. So this subset of patients were excluded from this Emperor reduced trial. Other silent feature of this study, this was a multinational, multi-center study, and white patients were 70%, 18% were Asian. So conducted in many continents. The poor patients in NYHA class were 75%. Important thing is mean LVF is 27%, quite low. 50% patients were diabetic. Estimated mean GFR is less than 60% in 48%, less than 60 in 48%. 70% were patient taking were ACE inhibitor or ARVs. RNI was being taken by 19%. MRA was being taken by 71%, since beta blocker were being taken by 94%. 31% patient had ICD implanted and 12% had only had implanted CRT. So the primary outcome was cardiovascular death or heart failure hospitalization. It was 19.4% versus 24.7% in placebo group. So there is 25% reduction in the relative risk reduction. If we see only the cardiovascular death, the reduction was not significant, only 8%. That is also confidence interval is more than 1. Major benefit came from the heart failure hospitalization. It was 13.2% in empagliflozin group versus 18.3% in placebo. So 31% reduction in the relative reduction in heart failure hospitalization. So this table will briefly show the major outcome: 25% reduction in primary endpoint, Secondary endpoints, there is 30% reduction in total heart failure hospitalization, first as well as recurrent. And second secondary endpoint was there is 50% reduction in the decrease in the renal event. So primary endpoint, 25% reduction. The same thing is depicted by Kaplan-Meier curve here. If we see the composite renal endpoints, the curve were start widening after 26 weeks of randomization. But if we see for the cardiovascular death hospitalization, the curve starts very early separating. So for the benefit, as it was initially briefed by Dr. Anshul, that the curve the benefit for the cardiovascular disease starts very early in days. Emperor reduced trial has major implication for clinical practice. After this trial has come into literature, with empagliflozin will have major impact on management of patient with CHF and reduce ejection fraction, whether or not they have diabetes. So, irrespective of diabetes status, they have come into the for the management of heart failure with reduced ejection fraction. And there is now compelling evidence that SGLT2 inhibitors should now be added to currently recommended treatment for this disease. The same findings here, the rate of heart failure hospitalization was 13.2% in empagliflozin group, and whereas it was 18.3% in placebo. So 31% reduction in absolute difference of 31% reduction in hazard ratio. If we consider only death from any cause, it was not significant. The same finding is reciprocated in this table. Another important outcome of this trial is the safety. So, for the serious adverse event, there is 14.4% in IMPA group, and whereas it is a 48.1% in placebo. Those with a cardiac related to cardiac disorder, it was 26.8% in IMPA and 34.0% in placebo group. So, not significant. Related to worsening renal outcome, definitely this has shown a benefit in decreasing renal worsening of renal outcome. So it was only 3.2% in impact group and 5.1% in placebo. Selected adverse events, volume depletion, not very much different in both the group. Only 9.4% has shown hypotension in impact group, whereas it is 8.7% in placebo. Symptomatic hypotension was also not very significant between two groups. 1.4% had shown hypoglycemia, whereas 1.5% in placebo. An important aspect of this drug, it should not be given in type 1 patient or patient with those are prone for ketoacidosis. But none of the patient in both group has shown ketoacidosis. So urinary tract infection, if we see the similar incidence in both the group. Genital tract infection was slightly higher in empagliflozin group. Bone fractures were similar, and lower limb amputation was also similar. So side effect profile, if we see that it's a very quite safe drug. So Dutch empagliflozin lower the risk of cardiovascular death or hospitalization in patient with heart failure. The same findings here that this diagram briefly describe the whole Emperor reduced trial. So 520 centers were taken and inclusion were 2 to 4. less than 40%. Total number of patients 3,730, median follow-up 60 months, and around 49.8% were diabetes. And 1:1 randomization was done with placebo and 10 milligram empagliflozin. And the event rate was 19.4% in EMPA group and 24.7% in placebo group. Whereas it is for the decline, the EGFR reduction was seen is in minus in 2.28, and reduction GFR reduction was 0.55 in EMPA group. So conclusion was that those among patients receiving recommended therapy for heart failure, those in the EMPA group had a lower risk of cardiovascular death or hospitalization for heart failure than those in placebo group, regardless of presence or absence of diabetes. We see the secondary endpoint, total hospitalization was significantly better in patient with in EMPA group. Composite renal outcome was significantly better in patient with EMPA group. All cause mortality was equal in both group. New onset type 2 diabetes among patient with pre-diabetes is equal in both group. Change in hemoglobin HbA1c between baseline and 52 weeks in patient with diabetes was significantly reduced in patient with empagliflozin. Systolic blood pressure has modest effect, non-significant effect in this trial, and confirmed hypoglycemic events were in both group were more or less similar. So by all these secondary point and primary endpoint, the interpretation is that patient it improves heart failure outcome among patients with symptomatic stable heart failure with reduced ejection fraction, those who are in guideline directed medical therapy irrespective of diabetes status. Although primary endpoint, the benefit is primarily reduced by reduction in heart failure hospitalization, and there is also significant benefit in renal outcome seen in this. And this is trial very much similar to DAPA-HF trial for dapagliflozin. But the only difference is that here the patients with severe LV dysfunction has also shown to have benefit with EMPA. Even though SGLT2 inhibitors were introduced as type 2 diabetes management drug, the EMPA-REG outcome trial and other indicated clear benefit in heart failure management. So it is another part of the benefit of this drug. They were introduced as a diabetic drug, but now they have gained popularity also in management of heart failure patients. This trial enrolled a dedicated heart failure population and conclusively shows a benefit in this patient population irrespective of diabetes status. So this have a prominent role in future heart failure management guideline. There are ongoing research on this molecule. There is head-to-head comparison of EMPA versus placebo in body composition patient with acute MI and type 2 diabetes mellitus. Earlier, we have excluded the patient, those who have with the ACS within 90 days in EMPERA reduce. So the subgroup analysis of embedded trial is ongoing. That will further emphasize about the safety of this molecule on patient with acute MI and type 2 diabetes mellitus. Effect of EMPA as add-on therapy on transtubular potassium concentration gradient in patient with type 2 diabetes, patient hospitalized for acute decompensated heart failure. So another subset of patients that were excluded in patients in EMPERA reduced trial is being studied in this trial or by transtubular potassium concentration gradient. The effect of EMPA on arterial stiffness as it improves the endothelial function, and it also helps in a ventricular arterial coupling in type 2 diabetes mellitus, and 1 year follow-up. So other many things will be studied in other trial. Thank you.
Okay, thank you very much,
Yeah.
Dr. Nirdesh, for this presentation. Okay, so we have a question. Sir, can you stop sharing the screen, please? Yeah.
Yeah.
We have a question. The question is for Dr. Anshul. Dr. Anshul, the question from the audience is, any cautions to be taken with empagliflozin and metformin combination for the patients, and can we give it during night also?
Yeah, there is no compelling indicator to be given only in morning time. Empagliflozin can also be given in the night also. Only thing is there might be some increased risk of diuresis and patient might have to get up many times for this thing, but this effect is also not that prominent as we see with the diuretics. So empagliflozin still can be given in the night also, but preferably in the morning time. Because the action lasts for 24 hours only, so preferably it should be given in the morning time only.
Okay, preferably to be given in the morning time. Okay, thank you, sir. Dr. Nirdesh, there is a question: which SGLT2 inhibitor is best for cardiovascular protection among empagliflozin and dapagliflozin, as per your clinical feedback? Means like as per your clinical experience.
There's no head-to-head trial that has between DAPA, EMPA, or CANA or A2. But as the literature is more towards favoring the EMPA, we have we have an EMPA-REG outcome as well as EMPA. So I would prefer EMPA over the other molecules for the better safety of the better cardiovascular outcome in patient with diabetes as well as in patient with heart failure with reduced ejection fraction. So.
Okay, thank you. So there is no more questions. So we are concluding the section, concluding the session, sir. And thank you, Dr. Anshul and Dr. Nirdesh, for your wonderful presentation and for sharing your wonderful and valuable experiences. And on behalf of Lupin, thank you very much. And we'll see you in the future meetings. Thank you, sir.
Thank you.
Okay, thank you, Shobhit. Thank you, Dr.
Thank
Anshul.
you. Thank you.
Thank you, sir. Thank you.